Greetings, Dr. Mark Winton here from the University of Central Florida Department of Criminal Justice, and in this video I'd like to focus our attention on Chapter 8, Drug-Taking Behavior, Fundamentals and Theoretical Perspectives. First, the authors point out that psychoactive drugs affect our behavior and also our experiences through their impact on how the brain operates. And so I think we pretty much know that, and that was mentioned earlier. And then they get into how drugs enter the body, and the four principal routes for drugs to get into the body basically are oral, injection, inhalation, or being absorbed through the skin or membranes. And they go through the advantages and disadvantages to the drug user for those types of administration. They also talk about how drugs exit the body, a little bit of the chemical breakdown, the mechanisms on organs, elimination, half-life, and so on. And also different factors that determine the behavioral impact of drugs, such as the timing of administration. Also, the possibility of interactions when two or more drugs are used close in time, and also the situation where the drug user needs more to feel the effects they desire, and also the personal characteristics of the user themselves. So the authors talk about some of the aspects related to drug interactions, the additive effect, hyperadditive, synergism, potentiation. One of the problems I would point out here, though, is, or one of the things I'd like to point out is, when I was looking at data and research studies, that you might find that different studies will present results, and for example, we should always consider the possibility that someone who is using drugs and has a negative outcome, an overdose, a death, that there may be multiple drugs going on that interacted in a very negative way to lead to that outcome. And so that's important to recognize that. One study I remember reviewing that when they reported the causes of death and the findings in the autopsies, they basically reported a good number of people who had been using multiple drugs at the time of their death. So that's important to look at. Also, tolerance. And they define tolerance as the capacity of a specific dose of a drug to have a gradually diminished effect on the user as the drug is taken repeatedly. And that's, of course, the problem where the drug user may start using more frequently or use higher dosage. And they talk about behavioral tolerance and cross-tolerance and some of the individual differences that are related. They also talk about dependence, which they define drug dependence involves a person having a strong compulsion to continue taking the drug. And they talk about physical dependence, which relates to taking the drug to avoid withdrawal symptoms, physical negative withdrawal symptoms, and also psychological dependence, where the drug user craves the effects which they find very pleasurable. And this is, of course, a big problem related to continued use and recidivism. Then they get into discussion of the DSM-5, which is the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, published in 2013. What I have here is the desk reference. I call it the pocket guide because it fits in your pocket. And it's basically just a brief overview, or basically it just gives you the diagnoses, but it doesn't give you all the great details you'd find in the very long and detailed DSM-5, which I believe you should be able to look at online through the UCF library. I mean, last time I checked, I was able to do that. And they have in there a section on substance use disorders. And so that's important to think about in terms of treatment and communicating with other practitioners who work in the substance abuse field. So it's a diagnostic and statistical manual of mental disorders. Certainly if you take any psychology courses, you probably not only read about this, but you actually go into details about the diagnostic categories and how a diagnosis occurs. Interestingly enough, I can tell you I work in the field much earlier. I started my career in the mental health field in 1984, and I started with the DSM-3. Then we had the DSM-4, and then we had the DSM-4 TR, text revision, and then the DSM-5. I actually have a nice collection of DSMs, and some changes have occurred over the years. I did not really see dramatic shifts from DSM-4TR to DSM-5, except removing the axial coding system, where that kind of threw me, because my co-author and I had just published a book and talked about applying DSM-4TR, published that book in 2013, and then shortly after the DSM-5 comes out, and that information is not accurate by DSM-5 standards, because things change. So of course you always want to keep up to date there. So they talk about substance use disorders, and your textbook gives you an overview that some of the behavioral criteria they group into 4 categories in general here, which is impaired control, social impairment, risky use, and pharmacological effects. And they also point out that they refer to substance use problems, not drug use, and addiction is not a term that's used in the actual diagnostic classification. And they also measure the substance use disorder from mild to severe, depending on how many symptoms are present within a certain amount of time. Listed in the DSM-5, you have 10 major substance categories there. And so you can have someone who can have 3 or 4 of those, and that would be listed in any report. So I'm really not going to go into detail about how to diagnose and assess, because that's really not part of the class, but I think it's relevant to take a look in your textbook and think about how diagnoses are made. There's a debate about the diagnostic classification schemes as well. There's always that notion that there is some clinician subjectivity when making a diagnosis, but there are some tools that can be used to assist in that whole process. But often we can use multiple resources, including the clinical interview, to ascertain if a substance use disorder is present. So why do people take drugs? And your authors point out there's a variety of reasons, some for therapeutic purposes, that to reduce pain or to treat a particular medical condition or to treat a particular mental health condition. And then, of course, there's recreational uses, which range from just for the pleasurable effects to hanging out with friends, to escaping boredom, to trying to self-medicate for a mental disorder. And then there's different models. There's the moral model, which views drug-taking behavior as a matter of choice. And then in contrast, there's the disease model, which focuses on the substance use disorders as a medical condition, and often viewing a combination of genetic and environmental factors influencing as well. And then the biopsychosocial model looks at the interactions between the biological, the psychological, and the sociological. I'll just tell you my own preference in my previous work. I've been retired for a number of years from the counseling field, so I wanted to mention that. I haven't actively seen clients in quite some time. But the biopsychosocial model was the model that I used when I practiced, basically. And the authors do really a nice job of summarizing the different models. And you know, the biological model focusing on the neurology, the neurochemical systems, and also you know, looking at how that's related to structure and function of the brain in terms of how drugs affect that, and genetic research that you know, a lot of the research points to genetic predisposition toward substance use, for example, alcohol abuse. But of course, society plays a role as well. You know, if someone has that genetic predisposition for alcohol abuse and they grow up in a society that just doesn't use alcohol and they never use alcohol, well, versus if alcohol is all over the place, then, you know, the risk is much higher. And some of the genetic research, you know, some of the evidence for that looks at children of alcoholics and the identical versus fraternal twin studies. But there's really no identification of an alcoholic gene, if you will. So there's probably a combination of factors going on, again, predisposition. And of course, people vary in how they react to different drugs. I mean, I don't know if you've ever been to a bar before. I worked in one back in my undergrad days, years ago, and you know, we would watch closely. I worked coordinating bands and music, and also playing music and playing in a band, things of that nature. So I'm in that bar, and I'm observing, and I'm free of any alcohol. So, you know, when we worked, we didn't drink or anything of that sort. So I had my regular observational skills. Actually, I studied when there was downtime. But when things got active, you know, you see people come in there and you talk to them and they'd be fine and everything. And then like 3 hours later, they're a whole nother different person. They're aggressive, antagonistic, slurring their words, tripping. You know, and I can remember, you know, we'd go out the back door to take a break, and there'd be people out there smoking marijuana, people urinating, all kinds of stuff going on there. And you know, you never see that like at a restaurant at 1 o'clock in the afternoon or something of that sort. So, you know, it was going, and fights that break out toward the end of the evening, last call for alcohol. And that's when I said, we need to start packing up our equipment pretty quick. And people were abusive. And so, you know, but it's very interesting to observe all that. And a lot of it also related to the socialization process as well. So, you know, that whole sociological aspect was very relevant. And so there's some different psychological perspectives on drug abuse that are discussed. The behavioral, cognitive, motivation, and personality theories. And you can read through those. But what I do want to mention real briefly is De Clementi and Prochaska's trans-theoretical model that looks at the 6 stages of change. And I think these are really interesting to look at. This is part of a process of understanding not just change related to substance use, but also for other health behaviors as well. And I've talked to people that work in the healthcare field that use this in terms of healthier eating, exercising, things of that nature. But the trans-theoretical model has 6 stages of the change process. And so, you know, it may be a lot easier to become a substance abuser than to stop being a substance abuser. And so when you start looking at, you know, if you have someone who is abusing substances and it's a problem, well, let's look at these stages. The pre-contemplation stage is basically where there's denial. The person doesn't plan to make any changes. No problem, no problem. I go out, have 4 or 5 drinks a night, come home, I'm fine. I don't know what you guys are talking about. The second stage is contemplation, where the person recognizes a problem but they're not ready to change. So that person comes back in, says, you know, yeah, it's kind of a problem. I got pulled over, got a DUI, I have to go to court now. This is going to be a problem. My job is maybe at risk, so I have to rethink things. And then in the preparation stage, they're ready to take action. It might be small steps, but they're ready to take action. The person comes and says, I want to reduce or stop my drinking. I don't want to have these problems anymore. I got to go to court. There's going to be a hearing. I'm going to pay some fines. I'm going to have to go to special program, and so I'm thinking about action. It's the 4th stage, where they get into treatment or they're making clear changes. In this case, maybe the person actually gets into a rehabilitation program, and they're motivated to make changes now. And the maintenance is continuing to make progress, that they participate. I mean, people can go through these programs and just sit around and fake it, if, you know, pretend they're making changes, and that's not really beneficial. It's a waste of time of the program, it's a waste of time for the person. You're going to see recidivism. But if someone really has that desire to change, then, you know, you can see some change. And then the final stage, termination, is that they don't want to go back to that. So they may use other support groups. They may use AA, for example, and to try to make sure that they don't slip back or recidivate into their alcohol using problems. And a lot of this is related to the motivational interviewing that's used to help people move through these stages. But, you know, if you work in the field, there's often resistance to change. That's just the reality of it. Bunch of really neat information about the sociological perspectives. As some of you may know, my doctorate is in sociology, so I love sociology. Just so many wonderful theories in sociology, and looking at, you know, the groups and the different ideas. For example, anomie and strain theory, and how that relates to substance abuse and people feeling anomie, alienated, not sure of what the rules are, and Hershey's social control bond theory, looking at how groups bond families, religious institutions, schools, and communities, and how that relates to substance use, and of course different types of substances. That's a really useful one, you know, for the juvenile population. And then differential association theory, looking at how people learn how to take drugs. And then labeling theory, and the authors talk about primary deviance and secondary deviance, or primary, the person experiments with the drugs, and it's kind of temporary, kind of checking it out, but then if they continue to take it and get involved in the drug lifestyle and culture, secondary deviance is where they internalize the label of being a drug user, a substance abuser, whatever label they take. I mean, I know when I was working in the field, people would come in They're proud of their drug use sometimes. They'd brag about it to me, or in the group they certainly would, as if it was a good thing. And, you know, my goal, of course, was to reduce that or help them desist from using drugs, you know, period. And, of course, the symbolic interactionism, symbolic interactionist theory related to labeling, but the whole idea of people, you know, learn how to interpret the meanings of the effects of the drugs and the drugs that they use in groups through the socialization process. And the famous study I can think about, read years and years ago, was Howard Becker's Becoming a Marijuana User, where he looks at the person has to learn how to interpret the experiences. Then the authors spend a little bit of time talking about risk factors and protective factors, and they go into more detail on using the biopsychosocial model in terms of risk assessment and also treatment. And again, you know, you do a comprehensive assessment, you can kind of figure out where the weak and strong points are. You know, you also always want to look at the protective factors. What are some of the strengths in the person's life that can, you know, be helpful? A lot of times you got to bring in the family if possible, and that's helpful, family therapy and interventions. And so this chapter really has a lot going on and really a lot of useful information. We're trying to think about the actual behaviors. And like I said, I really like looking at, you know, respecting the biological and psychological models, of course, but I really like, I think, looking at sociological models, because I was working in, you know, nightclubs. I kind of used that model to see how things were going on, and it made a lot of sense. And then as a therapist, as a counselor, though, I use, you know, the biological and the psychological and the sociological, that biopsychosocial model. And it may be involving, you know, that to handle the biological part, since I'm not trained in that area, I would refer to the psychiatrist on staff. And the psychiatrist would handle, you know, that medical aspect. And then, you know, the family, I'd refer to our family therapist. And you know, I did mostly group therapy, and individual therapy and substance abuse was usually a part of a larger set of problems going on. You know, that might get someone who's using marijuana, cocaine, and alcohol, you know, some adolescent who's doing that. But the reason they initially came in to see me is because they beat someone up really bad at school and got, you know, suspended. And so you know, we do an assessment and try to find out about drug and alcohol use. And, you know, there's all kinds of ways to interview to get, you know, decent information. And what I've seen is, you know, again, if you learn these interviewing skills, which are very teachable, and you work in the field, you get a lot more information if you understand the appropriate ways to interview. So a lot going on in that chapter, but I'm going to wrap it up here. It's getting a little long. Thank you very much.